afternoon. Good afternoon. I think we're going to go ahead and start this last session. We realize we are between you and the reception, drinks and appetizers. So hopefully this will be a pretty lively discussion. We're all pretty passionate about this topic, Medicare competitive bidding and the impact it has had on patients. So I'm the moderator. I'm Deanne Stahly. I work for Gary doing diabetes projects at National Minority Quality Forum. And so I'm really going to just give you a little bit of background and then just turn it over to these two because they are the experts. So just to give you some background, among the 29 million people in the US with diabetes, almost 26% of those are age 65 or older. And given the ongoing epidemic and the rising costs of diabetes, it's critical that healthcare resources be allocated for these patients when they need them. Among Medicare beneficiaries, patients with diabetes consume over 32% of total Medicare costs. So this is an issue that's not going away anytime soon. And a key strategy for preventing or reducing the occurrence of hypoglycemia, a very costly complication with diabetes, is the use of self-monitoring of blood glucose, which provides immediate information about blood glucose levels and allows the patient to accurately dose insulin. So I'm going to just give their beneficiary access to SMBG has been disrupted. And Nancy's going to talk about it. In January 2011, CMS initiated its competitive bidding program that was intended to save beneficiaries money, but really intended to save Medicare money as well. So without any more delay, let me introduce former Congresswoman Nancy Johnson from Connecticut. After serving 24 years in the U.S. Congress, Nancy joined Baker Donelson because she shares the firm's commitment to service excellence. She served 18 years on the House Ways and Means Committee and played an integral role in the passage of every major tax, trade, and healthcare initiative during years of rapid technological and political change and the globalization of the economy. Ms. Johnson is widely recognized for her acumen and sound analyses of healthcare, tax, and trade policies. She's a powerful advocate on these issues for the firm's clients. Ms. Johnson's legislative record is a testament to her strategic expertise and ability to build coalitions. She has been recognized frequently for her leadership on such disparate issues as manufacturing, health policy, fair tax and trade policy, child and family issues, and the environment. Ms. Johnson is an authority on health policy and, as such, a key member of any team seeking to negotiate policies governing Medicare or developing a universally accessible health care system. As a member and then chairwoman of the Ways and Means Health Subcommittee, she introduced the National Children's Health Insurance Program and was a principal author of the Medicare Modernization Act, which is why she's here to talk about competitive bidding. Her many years of service have given her a deep knowledge of the healthcare delivery system, including the need for systems change, quality measurement, and payment reform to improve quality and efficiency. She introduced the health information technology legislation that led to the establishment of the Office of the National Coordinator for Health Information Technology and continues to fight for broad adoption of HIT to reduce medical errors and improve care quality. Her broad knowledge of the many challenges in this area, from deployment to privacy and security issues, enable Ms. Johnson and the Baker Donelson Health Policy Team to guide and represent those interested and affected by technology and systems change in the health sector. So please welcome Ms. Nancy Johnson.
Thank you, and it's very, very nice to be with you today. I was at the preceding panel, and I'm very pleased to see so many here. But the problems they were talking about at the preceding panel, and I'm sure you've been talking about all day, are all going to be profoundly affected by what we see happening in competitive bidding. So I want to give you a little background on how this program came about, because I don't think you can quite understand what's happening without that background. So, well, that's right, I'm supposed to move these, excuse me. Why doesn't that go?
There it goes.
Oh, okay. Just to talk a little bit about the birth of competitive bidding for durable medical equipment. It was passed in the bill called the Medicare Modernization Act that provided prescription drugs for seniors. And that was extraordinarily controversial. That bill was more controversial than the Affordable Care Act at the time that it was passed, partly because it began to look to the future of Medicare. And what was the future of Medicare, given a decade of extraordinarily rapid development in health sciences and treatment capabilities and diagnostic capabilities? So we were really grappling with, and had been for quite a few years. I introduced a bill to do a pilot on chronic disease management. And you never heard much about it because it was done all wrong. You know, I mean, it was really hard to learn. And you notice we haven't done bundled payments yet. It's hard to learn how government integrates care, but it's where you have to go because it's what patients need in today's world. So the Medicare Modernization Act, you'll notice, began new preventive benefits. I worked hard to get nurse practitioners and those people reimbursed by Medicare because that's the first element. You have to pay people if you want them to work for you. And then we got into preventive benefits. Then we got into screenings for diabetes. We noticed that there's disease management mentioned among the things that Medicare modernization brought to the table as a tool to help seniors get the health care they needed. And in the drug plan, probably the most effective tool that we passed in this whole bill was passed, and that was medication management. So we wiped out, one of the reasons that bill cost $40 million less than they had anticipated, unheard of for a new entitlement, was because it eliminated a lot of overuse. It encouraged the substitution of generics for prescriptions, and it eliminated adverse reactions. So it did a lot more than just provide access to seniors for medications they needed. It assured that they got the right drugs and not the wrong drugs. So it was a huge step forward, but big bills that attract a lot of attention like that, because the structure through which we delivered those drugs was not bureaucrats making the decision as to how each one should be paid for, but a competitive system. And we had passed that bill 3 times in the House before the Senate even passed a prescription drug bill. So there had been 5 years of attention to the competitive structure. And after every year when we pass it through the House and nothing would happen, those people would come back and they'd say, you know, you're doing it wrong this way, or you should fix this, or you should fix that, or if you do this, this is going to happen. And so really the competitive structure had all those years of careful thought and vetting and people involved in it, people from all different perspectives, from insurers, but patient groups. So we were able to develop an effective competition that also reserved for seniors the opportunity to get a plan that had their form of whatever drug they needed the cheapest, and somebody else could get the same drug in that category that some other plan had driven the price down on. So the competitive mechanism had received enormous amount of attention in the Medicare Modernization Act, and when you pass a big bill like that, often smaller but very controversial things get dragged along with it. And so means testing of premiums, which AARP had fought for decades because they didn't want Medicare to become a welfare program, was passed in the Medicare Modernization Bill, and competitive bidding for durable medical equipment was passed as a part of it as well. The whole idea of competition for lab tests and things like that was new. It hasn't gone very far because it's truthfully very hard to do. But in spite of the fact that in the drug portion, we had laid the rules out clearly. So you couldn't just offer somebody all the cheap drugs and not the expensive drugs, or drugs in one category but not in categories where they were very expensive, and get away with it. So the rules of competition are extremely important. I mean, one of the reasons in my mind the exchange plans are having trouble is that the rules are wrong. And so it's very hard for those plans to participate and offer to people what people really need. That's a different story, but rules matter. And we laid out good rules for the drug program, but we did a very nice statute about competitive bidding, but we paid no attention to the rules of the competition. We were going to let the administration do that, and sure enough, they did. And the problem is that they did it from the point of view of their tradition of controlling prices. So their rules were truly peculiar and resulted in a very peculiar design. They used non-binding bids, so you could bid, but you didn't have to take the contract if they offered it to you. Worst of all, they used a median price, and with a median price, you lose money on the expensive things. So you have to a senior not only has to have find a plan that offers that, but also has made enough money in the things below the line that they can afford to deliver that product. So it creates a very different market dynamic for both the senior and the supplier. And so the lack of rules meant that the program ended up with unworkable rules and a total lack of transparency. I mean, in the first round, everybody commented on it, GAO, everybody commented on. A huge number were knocked out on the basis that they were not financially capable. Their finances didn't pass muster. Now, these were stable companies. They had had their bids looked at and reviewed by experienced institutions and accountants, and they could not find out why they were knocked out. On the other hand, some plans, like one little guy who had a very small business in diabetic testing supplies, got no contracts in diabetic testing supplies, but he got contracts in 5 other categories in about 14 other states. Now, what were the capital requirements that he had to have to demonstrate that within 6 months from the time he got the contracts, he could ramp up and actually deliver? So there was very little, it was a real non-transparent system about how the bids were managed, who was allowed to succeed, and so on, and no enforcement of bidder responsibilities. That was equally bad. So you were supposed to be licensed. If you weren't licensed, oh well, nobody seemed to notice. And about a third of the bidders in the one state that got public attention, Tennessee, were not even licensed to do business in that state. When that happens, it means that you've not only shrunk the suppliers, but a lot of your winning suppliers aren't going to produce. And in the second round, more and more of the suppliers were from out of state in these very big competitive bid areas, and they didn't produce, not throughout the competitive bid area, which was what they were mandated to do. So you see, for many reasons, there was a severe access problem created sort of in the first year. And that has caused extraordinary problems, although it was not tracked. Access issues were not tracked by CMS in their evaluation of the program. You see that there's no judicial review and so on. I won't go into that, but it made problems in the program very hard to deal with. So in 2009, CMS started implementing the first round of competitive bidding, and it went terribly. I mean, it was, people couldn't find suppliers, there were all kinds of complaints, the quality was down. I mean, it was really, really a mess, and it was so bad that Congress stopped the program after the contracts were signed and had been in place for 2 weeks. I mean, that's how, I've never seen Congress do that before or since, after contracts are signed and the program is in progress. So it was suspended in MIPA, and then some new rules were put in the law. Most of the problems were agreed to that they would be solved. However, when round 1 rebid was brought out, it actually sort of ignored the law, and we'll see what happened. in 2011. But in 2010, when that rebid was bubbling up and coming forward, and there hadn't been much change, you could see that through the first months of the bidding process, which takes about 6 months, and all the old problems were just resurfacing, just as the way they had been. So it came to the attention of a couple of people who did auction work in governments, not only our government, but internationally, and knew a lot about auction structures. And they wrote a powerful letter to Chairman Stark, who was chairman of the Health Subcommittee on Ways and Means at that time. And I saw the letter that he sent forward to HHS. First of all, this letter was signed by 167 auction experts and economists throughout the country, saying that this would be catastrophic, that it would erode quality, it would erode service, and in the end, it would not supply what people needed. And it not only said what was wrong and why it was wrong, it said this is fixable. Fix these flaws, and you will have a good competitive bidding program that'll push prices down, but provide the quality goods that people need. So when we got, after he sent out the Federal Register and some other materials for them to read to see what the structure of the program were, back came these kinds of remarks. I mean, it was unbelievable what people really said. Look, it will just lead to massive fraud and corruption. Frankly, I see that happening. The only states that had used it in Europe, which actually were Italy and Spain, had disastrous results, that it guaranteed failure. The obvious flaws were so serious that it was hard to conceive that CMS would push ahead on a thing like that. So there was no one who spoke up in support, not one voice who spoke up in support of the structural design that CMS had chosen. But over and over again, at every meeting with senators, at every meeting with House members, there was a very calm, we're saving a lot of money and no one's being hurt. And that mantra was very hard for members to overcome, though they were hearing a lot of stories from their constituents that were profoundly concerning. So in 2011, CMS was rolling out this, this was the rebid now, so this is the first real rollout of the competitive bidding program that lasted more than 2 weeks. And they rolled this out in the 9 competitive bidding areas. Diabetic suppliers were reduced 95%. So in those 9 areas, if you totaled all the diabetic suppliers together in the mail order sector, which was where the competitive bidding was at that time, 95% were put out of business. It went from 500 to 20. You can imagine the number of people scrambling for a new provider and that kind of thing, and how many, I mean, some of them accepted the bid but couldn't expand the number of people that they were going to supply because the margin was so small. So the reduced access was even bigger than the reduced number of suppliers because some of them were not available to new entrants into their plan, and in fact, some of them provided no one and just went out of business. Again, there was this just voluminous anecdotal evidence about the problems emerging, and finally, the 167 experts and a lot of their friends, I mean, there were Nobel Prize winners amongst these groups, wrote a letter by 244 experts directly to the president about this program and the disaster it was going to bring to patients, and yet how fixable it was. So by 2013, all those efforts failed. I just tell you about them because it wasn't unknown. It was not mysterious. It wasn't a lack of knowledge. It was just a determination. First of all, it was an antagonism to private sector mechanisms setting prices. You know, that antagonism is still there among Medicare Advantage, and it's there to some extent in the drug program too. But it was very intense in these smaller areas. But by the 2013, in the second round, the suppliers of diabetic supplies were reduced by 98%, so there were 18 left out of 1,000. Now, this is nationwide mail-order diabetic supply providers. So 18 were left out of 1,000. Meanwhile, as part of a debt ceiling bill, the price they were paying the mail-order people was imposed on the pharmacies. So retail pharmacies began struggling with this terrible issue of price that was imposed on them in 2014. And now, 70% of all suppliers have been eliminated in the diabetic supply area. And in this upcoming round, because the third round has been bid, it goes into effect July 1st, there's another 20% cut. When you cut that many suppliers out, both retail and mail order, there's going to be an effect. I had never in my 18 years on the Medicare, the committee that governed Medicare, seen such deep cuts and never saw such a change in the supplier community. I mean, sometimes we try to do that. I never saw a supplier community, just by reimbursement policy, destroyed the way we have destroyed the supplier community for diabetics. But through all this process, the evidence that we had was always sort of anecdotal. It was never on the health of the seniors. So no member, when faced with CMS saying we're saving all this money and we're not harming anyone, we couldn't get the evidence of harm. It's a relatively small number of seniors that are even eligible for durable medical equipment, about 3 million out of the 40 million seniors. Or whatever it is. So it's a rather small group. They're very sick. They all have chronic illnesses. It's a special benefit system for people with chronic illness. And so in the end, we have a situation now in which not only is there another 20% looming, but there's a new payment system looming that goes into effect for every competition in the future. And in that new payment system, the maximum bid will be the current price. So, and there'll be no adjustment for inflation. So if you do a 15% a $15 an hour wage, whatever happens, if oil starts going back up, all those things that happen, there'll be no adjustment. So frankly, this is the most serious crisis that I have ever seen in access to needed care. And I'm delighted. I just want to congratulate the next speaker and the National Minority Quality Forum for being the first ones to do any significant research. And this has been peer-reviewed. I've sat with Gary as he's talked to MedPAC, and MedPAC has been awed by the quality of the research that National Minority Quality Forum has done on the patients, on the people in the program. No one else has done that. So I'm thrilled to be here today, to be part of talking about this with you, because the time is now. Thank you.
That was great. And you'll hear from Nancy again at the conclusion of this panel. Her passion is definitely catching. Now I'm pleased to announce and introduce Dr. David Marrero, who received a BA, MA, and PhD in social ecology from the University of California, Irvine. He joined the IU School of Medicine in 1984 and became the J.O. Ritchie Professor of Medicine in 2004. He was a member of the Diabetes Research and Training Center and served as director of the Diabetes Prevention and Control Division. He is currently the director of the Diabetes Translational Research Center. Dr. Marrero is an internationally recognized expert in the field of clinical trials in diabetes and translation research, which moves scientific advances obtained in clinical trials into the public health sector. He helped design the Diabetes Prevention Program and the Triad Study, which evaluated strategies to improve diabetes care delivery in managed care settings. He has more than 200 publications and has been awarded numerous grants. Dr. Marrero was twice awarded the Alain von Son Award for Diabetes Patient Education Tools by the American Association of Diabetes Educators, was nominated to Who's Who in Medicine and Healthcare in 2000, served as associate editor for Diabetes Care, and is currently the associate editor for Diabetes Forecast. He was selected as Alumni of the Year for University of California, Irvine in 2006, and the Outstanding Educator in Diabetes in 2008 by the American Diabetes Association. He is currently the President-elect Healthcare and Education of the American Diabetes Association. Please join me in welcoming David Marrero.
Nice.
You gotta wonder where they find that stuff, you know? Wish my mom was here. She was like, is that what you did? I'm really pleased to be here to talk a little bit about this issue. As the distinguished first speaker pointed out, this is a really serious issue. And I'm a diabetes researcher, that's what I do, okay? So I wanna give a little context because sometimes we lose sight of the numbers. There are 28 million people with diabetes in this country, and more disturbingly, there's about another 87 million, that's 1/3 the US population approximately, that is at really high risk for developing diabetes. So if we don't do things now that control this, it's gonna be a tsunami of cost and impact. It's just an extraordinary public health crisis of our time. So when this program came out, and as my first colleagues pointed out, there were some issues. And we had a chance to look at the data set from CMS. This wasn't us going out and collecting data. This was a data set provided that we could actually look at and try to figure out what the heck was really going on. So I'm going to pace. I had 8 brothers and sisters. I learned that if you keep moving, you don't get hit. So I can't help myself. The study had a simple goal. We wanted to assess the impact of the implementation of the competitive bidding process, herefore to be known as the CBP, on acquisition of self-monitoring of blood glucose supplies, right? This was amongst the Medicare beneficiaries with diabetes within the 9 test markets, as was already pointed out. The population data was from 2009 to 2012, and it showed the supply acquisition records for all the beneficiaries and with the diagnosis of diabetes and a record of insulin treatment. Okay, that's approximately 500,000 folks that were used in this analysis. Now, this is what's important. The data is very clear. And one thing I should add, by the way, I'm the immediate past president of the American Diabetes Association. I actually went through that process, became the president, and just finished that December. But I know something about diabetes, and I know one thing is very, very clear. If you're on insulin, you need to test. If you can't test, you don't know what's going on, you can get in tremendous trouble very quickly, right? You can go into the hospital for hypoglycemia or low blood sugar. You can go in for high blood sugar, hyperglycemia, and both of those can kill you, okay? So it's really important that we have this assessment technology. I myself am a diabetic patient of 40 years. I could not survive or be up here today unless I knew what my glucose was, all right? So very, very important issue. Just want to make sure we're clear on that. So in 2009, the records were separated into 2 cohorts of patients, 2 groups, with records for both insulin and self-monitoring supplies. Now, most of these people are type 2 diabetes. That means they're adult onset, as we used to say in the old days, but they need insulin. It turns out that about 40% of people with type 2 diabetes will go on to need insulin. Their beta cell just fails over time, and it requires that they supplement with insulin. So this is not something that's going to go away or only apply to juvenile onset, as in the old terms, or type 1 diabetes. So we had inclusion in the test sites, the test, which is 43,000 people, and all the comparisons were made to everybody else, all right? So we have another 485,000 people. These are large numbers, okay? It lets you look for statistical things that are very effective to diagnose because you have such a big number. It's not like I have 6 people and maybe it applies to everybody else, maybe it doesn't. So we use CMS definitions to calculate beneficiary acquisition of insulin and self-monitoring supplies, test strips for glucose meters. Full insulin acquisition was defined as greater than 80% of the proportion of days covered. Any study that looks at medication utilization uses this as the benchmark. If you take your drugs about 80% of the time, that's considered to be pretty adequate coverage. Because the reality is most of us don't take them very systematically, and people in diabetes are legendary for the inability to take medications with great focus and accuracy, okay? It's very well known in our area. We then looked at self-monitoring of blood glucose acquisition, which was defined as coverage for 80% of the patient-covered days. So in other words, are you using them pretty regularly, okay? And these, again, are very standardized definitions. Now, patients, this is where it gets a little tricky, but go with me here. Patients with records for full insulin acquisition, so they're getting their insulin scripts, they're using the insulin by any conventional definition, and either full self-monitoring acquisition, meaning they're using strips at a rate that is predictive of daily use, all right? We call that full, or partial acquisition for self-monitoring supplies. So they're taking the insulin, but maybe they're not using their strips as regularly as one would like, okay? The insulin records show that about 65, almost 66% of people, the beneficiaries, were treated with short or rapid-acting insulin. This includes premixed insulins and with or without long-acting insulin. Now, this is a little tricky, but this is really important. When you have diabetes, right, there's two basic kinds of insulin. There's what we call a basal insulin or a long-acting insulin. You use that to sort of put a background of level of insulin to your system, okay? Many people who are older with type 2, in fact, use basal insulin only. Surprisingly, in this population, they were using also rapid-acting insulin, which is insulin that you take to cover your meals, right? It's very quick onset, and it has a big punch. It's designed to cover the food that you're eating. This is the insulin that if you're going to get into serious trouble with low glucose, that's the insulin that you watch out for, not usually the basal. So surprisingly, a large percentage of people in this beneficiary cohort were using very potent insulins that could cause hypoglycemia or low blood sugar, okay? We also saw that 180,000, 34%, were just using basal insulin. That doesn't mean they can't experience hypoglycemia or low blood sugar, but it's less likely. So surprisingly, a robust group of people using very potent insulin regimens that are known to be associated with low blood sugar, which is known to cause serious problems. Okay? We also set up what we call propensity scores. So we matched people in the control group, if you will, with the active group and the beneficiaries to see whether they look the same. One of the problems you get into when you have 500,000 people in a study is you need to match people so you're comparing apples to apples and oranges to oranges, right? So I want to know that, you know, you and I look the same age, same gender, same whatever, so I can make a comparison between a control sample or comparison sample and the active sample. So we not only had this big group, we chunked out a group and matched them for the comparison. I'm going to summarize the findings because this is where we're getting into and this is where the action hits. And I really like how you framed that because it's all true. We know that the 4-year survival was significantly associated with full acquisition of self-monitoring and blood glucose supplies amongst both the test and the non-test beneficiaries. In other words, control people versus the ones in the active bidding markets, right? We know that in fact there was an impact on survival. And it was evident and statistically significant. People in the test markets were doing worse, very clearly defined. We saw a notable shift in self-monitoring of blood glucose acquisition from the mail order to the retail channel that was seen in the test cohort, but not in the non-test cohort. What does that mean? What that means is that in people in the test markets, it became less likely for them to use test strips, okay? Now, we'll talk a little bit later about why that might be, but they weren't testing as much as they had been, or like people who look just like them, similar economic, social, racial status, people who didn't have this test market experience kept their testing rates kind of constant, right? Which makes kind of sense if you have diabetes. We know that an alarming percentage of beneficiaries in both the test and the non-test cohorts, you can think of test and non-test as exposed to the competitive bidding marketplace, not exposed to the competitive bidding marketplace, right? They had no record of SMBG, however, a higher percentage were observed in the test cohort. What that means is people stopped testing in the test markets. They stopped testing. Now, understand, like I said earlier, if you have potent insulin regimens on board and you stop testing, that has clearly been associated with increases in mortality and morbidity in any other study in the land. If you look at research, it will show you that if you need to test to adjust your insulin, if you don't do that, things start to go bad. Yeah, you don't know where you're going. You don't know what your drugs are doing. You don't know whether they're going to drop you like a stone or let you function adequately. So that became a significant observation, that people just stopped testing. And finally, we saw that competitive bidding was significantly associated with an increase in the percentage of test beneficiaries with partial or no acquisition. So again, we saw this shift in people testing. They were testing here, and all of a sudden they're testing down here. I'm going to ask you a question, because I get really tired of talking and listening to myself. I want somebody to give me their perception of why do you think that happened? Why do you think people who were testing, humming along, stopped testing? You may speak up. I am a professor. I'll call on you if you don't. So, anybody? Be creative. I'm sorry? The cost, you said? Actually, the cost of the test markets was substantially lower. You know, the one thing they did get right is they reduced the price. Okay, so I don't think that's it. So if I could get it more cheaply and not have to worry about it, why would I test less? Interesting question. They felt better? I would suspect, I don't know if that's correct or not, I would suspect, as a person who uses insulin, that when you don't know where your insulin's at and you can't adjust to regulate it, you feel like crap. And that's a technical term, okay? I mean, you do not feel good at all. Very high or very low glucoses cause you a lot of cognitive impairment. They can cause you anxiety. They can cause you fatigue, frequent urination, dry mouth. So I don't think that's correct, that they felt better. All right? Anybody else got another guess? How about, over here. Inconvenience. Tell you a story. My mom is 89 years old, and she was in a test market. Surprise, surprise, has diabetes, takes insulin, all right? My mother calls me up one day and says, hey, I just got this letter that says I can't get my testing supplies where I used to get them, through the mail, from this company. And I got to figure out how to go someplace else and get, I don't know how to do that, okay? I'm 89 years old, she's not a big computer geek, right? She could not figure out how to get her testing supplies, suddenly. So she went through a period where she had no testing because she ran out, right? And then she couldn't quite navigate the experience of renegotiating a new supplier and a new set of test strips. So I went over to my mom's house, because I am a good son, and I helped her engineer this deal, right? So then she got a new meter and new test supplies. No education with this, but luckily, because I am an ADA guy, I know how to do this. So I taught my mom how to use these new supplies. So I think you're partially correct. What do you think happened, though, when she did that? I think it's explanatory to some extent of what I think is going on here. What do you think happened? Anybody? Say that again? She didn't forget how to do it, although that's a highly likely scenario for many people, right? But she started getting results that didn't make sense to her. She's been doing this a long time, right? And she calls me up one day, like mothers do, and says, son, you're the diabetes expert. How come it says this, but I didn't eat anything? It suddenly gave her a much higher number, which would suggest that she should adjust with insulin. She should make a dose correction of a potent, rapid-acting insulin. And I thought, well, Mom, you had something. Come on, tell me. You drinking again? You know, what's going on? And so we kind of went around and around. Well, my mom said, no, I don't think this is correct. I said, I'll tell you what. I'm going to drive over there with my meter, and we'll check it out. Well, maybe your meter's, you didn't do the control solutions, or your strips are bad, or something like that. Lo and behold, it turns out that my mother had a meter system that was wildly inaccurate. It wasn't reading the same as her traditional meter, or the one that I would use, okay? So she suddenly is shooting in the dark with numbers she doesn't trust. So guess what my mom decides? Well, why should I test if I don't believe the numbers? Okay, so she stopped testing. See the circle here? It's like it's an inconvenient phenomenon. So it's harder for her to get the strips. It's harder for her to get reliability, perceived reliability in the value. And it's harder for her then to justify, why am I banging my finger with a sharp instrument to get blood out? She didn't like that ever. That was always a problem, right? So it became this sort of interesting phenomenon. And we have to wonder whether competitive bidding has an impact on product reliability. Because when you take the cheapest option that you can get, which is what, $10.41 or something like that?
Used to be 34.
Okay, there you go. It makes you wonder whether the product you're getting is the same quality as one that has been established and you've used for many, many years, and you developed a routine around it and a sense of reliability. It's like buying the cheapest car on the used car lot. Do you think it's going to run for 10,000 miles? Might, but it might not. So we saw that many, many people migrated from full or partial to no testing. We saw that. So people just stopped testing. My mom might be an example of why that happens. Suddenly, it was not a reliable experience. And if you make a mistake in an insulin adjustment with bad numbers, you are in serious trouble. You know what I mean? So if your number says you're too high and you take more rapid-acting, potent, short-acting insulin and you weren't too high, you're going to become really low. And it's going to happen pretty quickly. Then you have problems, okay? We know that migration from full or partial to no testing was associated with higher mortality. Why is that? People with, especially older people that have high glucose have concomitant chronic conditions that are very serious, like heart disease and like heart failure and other things. You're more likely to have strokes, stuff like that. So it's sort of a perfect storm. If I don't let you know you're too high and you don't adjust for it and you stay high for a sustained period of time, you're going to have other things come up and bite you in the rear, right? Because that's what diabetes does. It's the leading cause of most nasty complications. We also know that migration from full to partial to no testing was associated with women and if you were black. Now, I'm curious, because many of you are African American, why do you think that is? I don't have an answer. I'd just like to hear your thoughts. Someone say, you guys speak up, come on. Why women? Yes, ma'am.
Because you take care of other people first.
I think that's right. And if you got a really busy day, like my family was, 8 children, and my mom was a single mom working, 2 jobs, the whole nasty scenario, which I'm sure all of you are familiar with, right? Guess what? If I suddenly have justification to not do one more thing that's kind of a pain, in fact, literally a pain, that goes out the window pretty quick, my theory. So I think you're right on that. Anybody else? Why black women? Strips are cheaper now.
You have a lot of responsibility, and you don't want to give in to something that will take us away from that and not be able to take care of our family. Sometimes it can be fatal. That was the case with my own mother, who passed away because she had problems, just like you're saying, and didn't get to the healthcare professional in time to have it addressed.
I agree with you totally, and I'll add a little self-perception to that. I live in a city where very high percentage of people are African American, in Indianapolis, and I think black women are really smart and logical. They kind of look at the array of stuff that they got to deal with and say, you know what, if this isn't going to work very well, why do I do this? They're not quick to blindly follow a routine just because it's a routine. So that doesn't make sense to me either. So I sort of buy the same perspective. It's like, I talk to many people in my center and they say, doc, if this isn't telling me the truth, why should I listen to it? Interesting perception. Also, we know that migration from partial to no testing to full acquisition somewhat mitigates the effect of prior partial or no. So what that means is for people that actually went the other direction, they started testing more, they actually did a little bit better. Now, I think that the product they had wasn't as reliable, but some data is better than zero. You know what I mean? It's still, you have some advantage that's potentially there for you. Let's see. There we go. So why did this happen? Difficulty in securing the new product is obvious. Clearly, my mother is a single example of a phenomena. People couldn't figure out how to get to the new product. It just was more difficult. And when you're like my mom or your moms that are in their 80s and not firing quite as quickly as they used to, asking them to go online, figure out a supplier, disrupt their entire routine is difficult. Or, what was their choice? Their choice was to go to the pharmacy. My mom doesn't drive. She just doesn't drive. In Indianapolis, we have bus systems which are terrible. This is in Washington, D.C. and Indianapolis. We have no metro. We have buses that are spurious at best, right? And in downtown Indianapolis, there are 3 pharmacies, 3, okay? 1.9 million people, the 11th largest city in the country. You can't jump on a bus easily and go to the pharmacy. It was a big deal. So if you're suddenly telling me I can't get it mailed to me at home, which is much more convenient, now I got to do this complicated scenario where I'm trying to find a ride. Or we have things called jitneys. Are you guys familiar with that? Where people are actually making, in fact, it's the forerunner of Uber, I think. I mean, people making money to drive you places. The jitney guys were cleaning up because everybody had to start going to the pharmacy if they wanted product. You know, this is an issue. This is a problem. We also know that the product selection went way down. Many, many people complained to me at my center that I wasn't taught how to use this technology. You gave me a brand new meter. It's different than what I'm used to. I used this one for 5 years, 8 years, 10 years. Now you're telling me I can't use this anymore. I got to use this one. Or I got to figure out a way to get to CVS and pick up what I'm picking up, you know, for myself, but without the ability to do that easily. So there were several things that were going on. There's one other thing worth talking about here. I'll get to the recommendations in a minute. In fact, we'll just do the recommendations in conversation. One other thing happened here, which to me is disturbing. I'm a researcher. It's what I do for a living. And this study was not designed the way that I'm required to design studies that experiment on people, okay? When I do an experiment on any of you here, if I had you in my study, in my center, and we do these all the time, we usually have what are called data safety monitoring boards. People that look at the data who are independent of me and the people doing the study to say, you know what, you got a problem here. You got to fix this or stop, okay? That's very common. So in clinical trials, and I believe that this CMS compatibility was a clinical trial. It was clearly a clinical trial. We're impacting things that directly impact your health, right? That's clinical trial by any definition. If you're not monitoring the data or you're designing the study to look for problems, you've got a huge, huge issue there. And in my world, I can't get a study funded, I can't get it accepted by the Investigational Review Board unless I have those mechanisms in place. But what I think I understand now is the CMS really didn't do that. They just did the trial. Didn't ask you, nobody signed consent, you know, nobody had a choice to opt in, opt out. They were just subjected to a trial that could impact their health. Now, there were some ways around it, okay? You could drive to the pharmacy and get your old products and stuff. There were some ways around it, but they didn't design it in a way to make sure that was really happening. It was actually getting done in that way. Because unless you know that, you're not in a position to say, wait a second, let's stop this thing until we can figure out how to fix it, okay? Now, I hadn't seen your slides until today about all these people saying, geez, this thing's really not a good design, and there's all these problems, and we're gonna predict failure and stuff. I'm not surprised anymore, because I kept thinking, well, you know, why didn't these guys set this up like a clinical trial? You know, why didn't they have a data monitoring board? Why didn't they set up the design so they could see the signal of a problem before it gets so serious that we start to get statistically significant trends that say you're dying more, you're spending more time in the hospital, and your life has become a little bit more complicated? They did not do that. So in my recommendations, and the ones that are in the paper, we say that given the prospective approach taken in implementing competitive bidding, CMS should be held to the same safety monitoring standards as other clinical trials. Wow, there's a concept. Let's do it the same. So we all play by the same rules. I can tell you trial after trial that has shown that some drugs will kill you. And if you don't do that, they kill you, right? And so you want that mechanism in there to stop that trial before it gets out of control. And there's many examples of that. We also believe that CMS needs to demonstrate its ability to measure the effects of any experimental program so they can ascertain whether any, and I'm underscoring any, harm is being done. To me, it is harm when my mother can't rely on a product and stops testing. You've put her at jeopardy, and not on my watch. You know what I mean? Ain't gonna happen to my family. And I happen to run a diabetes center, so I could compensate. But most of you don't have people running diabetes centers who say, oh no, Mom, that's wrong. Let me show you how we can fix this. That doesn't exist. That's a big problem for me. And finally, Medicare beneficiaries need to be protected from harm before future efforts at benefits manipulation are evaluated. And you basically said it. Until this thing rolls forward, we're talking about a nationwide program now. And if you think the problems that we're seeing in this data set are happening, you can only imagine what happens when we cut the price even further, reduce the breadth of product that's available to people, and subject them to all the same issues I've just described up here. To me, that's a perfect storm. And it doesn't need to be tolerated. It doesn't need to be tolerated. And I suggest it shouldn't be tolerated on our watch, because it will harm people. It will make them sicker, it will make them die more, and it will really disrupt their quality of life. That's it, thanks.
Great. Yeah. So before we finish up with Nancy and her call to action, I just kind of want to reiterate what the National Minority Quality Forum did here. We kind of pulled together this group of experts, and I want to reiterate, we used CMS's data to really test their concept that patients have not been harmed by this. It's CMS's data. We are not pulling this data from anybody else but CMS. And that's where we found patients were dying at a higher rate, twice the number of hospitalizations, and 2 times the amount of overall healthcare costs. So they're not even saving the program money, which was one of their original intents. So again, we just want to emphasize here, NMQF has been part of this kind of data-driven education and advocacy, but it's utilizing CMS's own data. We also released a white paper in December that showed how flawed CMS's methodology was in trying to convince everybody that they're actually monitoring patient safety with the impact of this program. And we do have a copy of that in the back with a one-pager. But Nancy is going to finish up, and hopefully we'll have a couple minutes for questions.
I just want to add that all those economists and auction experts, the 167, the lead on that was a guy named Professor Crampton from Maryland. And he, using Medicare's own data, showed these charts where the total number of suppliers in the 9 areas was looked at each of the years preceding competitive bidding going into effect, and when it went into effect, it went like this. I mean, it was startling. It was awful. So I showed those to top staffers in the Senate. They sent them to Medicare, and they got the worst note back from the lead on the program. I won't mention names, but it was, oh, well, they didn't understand the program. Oh, well, they're not taking into account the natural lag between payment and claim. I mean, this is startling. Good researchers who have a good name don't make those mistakes. Then there was a guy out at Caltech, in the Caltech lab, a professor of economics, and one of his students took an interest in this program, and he ran it and came to disastrous results. I mean, there's been no secret about how this mechanism works, and it takes too long to go through all the details of how it works and what happened, but it's a known, you cut the price too low, and you have no choice. You have to if you're a distributor, you have to buy the cheapest thing on the market because you're not going to get paid any more of that. I mean, it's just stunning, and the reason it's very, very important, I mean, just think of the cost. In the preceding panel, everyone's trying to, and when we did Medicare modernization, we were passionate about it. The president was passionate about it. When they held that vote open for 4 hours, never been done since. The president got on the phone to the Republicans who were opposing this because it was a new entitlement to help them understand that in this day and age, if you don't care with the people with chronic illnesses and keep them out of the hospitals, there's no way you're going to ever be able to keep a healthy health benefits plan in place for seniors. So we've known this for a long time. We're searching for how to do it. And here, the secretary herself just came out funding a new preventive benefit through programs in the Y of younger, healthier Medicare beneficiaries to help them not get diabetes. But with the left hand, they're cutting the price so severely that access is actually so truncated that people are hospitalized because they can't test. Now it drives you nuts.
There's a couple of methodological things that are very intriguing to me. When they set up the competitive bidding process, they didn't randomize people into an equal distribution so I could get a sample that looks like the country, right? That's sort of how you do this kind of work if you do it right. And they chose markets on the basis of how many strips they sold. So the populations were quite different. So, they're comparing you guys to Indianapolis, which is not too dissimilar from DC, but they also had Phoenix in there, right? And Phoenix doesn't look like Washington, D.C. or Indianapolis. It's a way different market with different forces impacting it. So you take Indianapolis and Cincinnati, that was part of our network, right? Cincinnati has a much better bus system than we do, just how it is. And so you control for those things. You try to get the population to normalize, if you will. And if you don't do that, then wow, it's really hard to draw conclusions that make sense. And so one of the things that the CMS seems to be doing to me, which I find very intriguing, is they're doing huge studies. And boy, guys like me salivate over huge studies. I love these kind of big data sets. They're lots of fun. But you want to set them up in a way that you can draw really decent conclusions from it and say, this is in fact what we think will happen wherever we do this. And I don't know that. So when I looked at this data set, I thought, wow, these cities are really different. I don't know if it's going to work when I broaden into other cities and other states and other communities. That's kind of a problem, particularly when you don't build in a surveillance system to detect signals that say, we got to fix this thing. So maybe they ignored everybody else's input about you should fix this thing, but they shouldn't ignore their data. Their data says you need to fix this thing. It's gotten clear.
Yeah, one of the things that was very interesting was that they told the Congress that they were tracking everyone, and so they could assure them that no one was being harmed. Money was being saved, no one was being harmed. Well, you read their stuff, and they're tracking claims. Now, your data showed that people were hospitalized at twice the rate because they didn't get their product. If you have a claim, you get your product, right? So if you have a claim, you're likely to be fine. And the fact that they only, the General Accounting Office, GAO, did dissent from their comment that no one was being harmed. And they said over and over again in their reports, very politely, because when agencies criticize one another, it's very gentle. But they said very clearly, we do not agree that you can draw the conclusion from their data that no one is being harmed. And when I talked to GAO about that, they said, well, it's a methodological difference. And CMS and the newspapers would say, well, that's a methodological difference. When you see their study of methodology, I mean, it is not, there are no standards that any other research is held to that their research, their methods meets. It's quite stunning. Right. Now, you may think I sound harsh about this. I am a little harsh about this because after we showed them those charts, the next round of data that this researcher asked for, they held. He went through all the Freedom of Information stuff, and the people kept calling and said, no, it's complicated, but it's coming along, you'll have it. And then she finally said, yeah, it's all assembled, CMS has it, you'll have it in 2 weeks. It was never released. So this is a very serious, I mean, we are really in a terrible situation. The only real research that's been peer-reviewed that's about people and the impact of this policy on people shows they're hospitalized at twice the rate and dying at a more rapid rate. So
let's be clear about something, because the researcher in me feels compelled to say this. We can't draw causal inference from this data set. Right. We can't say that competitive bidding killed more people. It's not the right conclusion. You can say that competitive bidding is clearly associated with changes in test strip utilization. That's clear, okay? We could also know from the science that reduced testing increases morbidity and mortality. We know those two things. That's right. It's seductive to say, well, because these guys put this in, that more people died. I wouldn't be as heavy-handed about that. However, I would be very heavy-handed about in the future, design me a study so we could figure out this stuff before it gets so bad that we have a meeting like this. We shouldn't be here discussing this.
I am sensitive to that, the fact that there's no causal link. On the other hand, the figures he's taking are from the demonstration areas. Those demonstration areas were all areas in which the supplier community was diminished. In the case of Medicare, first in the case of mail order diabetic suppliers by 98%, I think it was. And then now, with the pharmacies all in it, 70%, all of the diabetic suppliers have experienced a 70% cut in reimbursement rate. Now, that's an extraordinary cut in 5 years. It's just extraordinary. And they're going to get 20% more in July, and thereafter, every year, the price can never go up, no matter what happens. What if a new meter comes in that's really terrific and easy to use and so on, but it costs more money? Can't be had. So this is, we really have to get that program suspended before July so that the research can be done to see what the harm is on other patient groups. And one of the most interesting groups, and this is part of the reason that I'm so passionate about this, because it drives me nuts. They found that 40% of seniors using insulin don't test in either area. Now, here is an opportunity for CMS to save real money, to figure out how do we get to those people? How do we teach them to test? What do they need? When managed care first came in the market many years ago, one of the companies in Connecticut, where I'm from, made big bucks because they figured out if they covered the single women in New York City and the single parents, and they made sure, and they would provide babysitters, they'd provide taxis, they would do anything to make sure that the women got to their prenatal visits, and that the women had all the support they needed in diet and so on and so forth. And of course, the number of low birth weight babies plummeted, and a low birth weight baby is hundreds of thousands in the preemie unit. So everybody did better, and it saved a lot of money. So there's that 40%. That's waiting for all of us to figure out, how do we help seniors who are on insulin but don't get it, that they need to test? And how do we have meters that are accurate so that anyone, no matter how isolated they are, they can do it, they can use it, and they can care for themselves. And their whole body will have that stable environment that allows them to ward off other diseases and to enjoy life. Right. If your insulin is going up and down, it's like anything else in your body. It does havoc when it goes down, it does havoc when it goes up, and it controls your life. You're like a puppet on a string. So I just would urge you to help raise your voices before, as soon as you can, right now, and help us with the Congress so they can understand that we need to suspend this program. Why is it that just in the competitive bidding areas, these awful things happen? Let's find out. What happened to the people dependent on oxygen? I mean, that also is a product that needs a lot of service. What happens when the service disappears? So I have you think I'm passionate. I have a decision by a judge about a group of disabled people who lost the ability to get a feeding tube that was specially structured for disabled people and didn't have so many cords, and they didn't trip over. Big long story. Anybody interested, I'll give you that reference. His name was Frank Donovan. But you saw on one of my slides that in the law it says there can be no administrative or judicial review. So he had to throw the case out. Right. But in his statement about that, he went through what an outrage it was that this disabled group of people were not allowed. I mean, they were given something, so it was costing you something, but not what they needed to thrive.
So do any of you have any questions you'd like to ask or discussion you'd like to?
We're running over, but you can tell we're all very passionate about this. If we have a couple of quick questions, we're more than happy to take those. If not, we're all available up here. Please join me in thanking our panelists. This passion is very real.
Thank you.
Thank you.